Okay, so she has newly diagnosed autosomal dominant polycystic kidney disease. Her past medical history includes hypertension diagnosed 5 years ago. Her family history is notable for multiple members with polycystic kidneys, including maternal grandfather requiring dialysis at 53 years of age, her mother requiring dialysis at 59 years of age. She only takes lisinopril for high blood pressure. The physical examination is unremarkable. Normal vital signs. The laboratory data are as follows. So the creatinine is 1.1, estimated GFR is 69, AST 24, ALT 19, alkaline phosphatase is 54, and bilirubin 0.8. So the liver panel is quite unremarkable, and the beta SCG is 0.3, so she is not pregnant. A recent abdominal MRI reveals numerous, diffusely distributed bilateral kidney cysts with a height-adjusted total kidney volume of 546 ml, and that puts her at Mayo Class 1C risk category. Genetic testing is done, and it reveals a truncating mutation in the PKD1 gene. She has a healthy 3-year-old child, and she does not plan on having more children. Which one of the following patient characteristics most supports initiation of tolvaptan? So we know there is a treatment for ADPKD available, it's Genarti. And which one of these characteristics actually makes her the most likely candidate? Is it because she has a PKD1 truncating mutation, which tends to be leading to a smaller protein and of course non-functional? Is it because she has Mayo Class 1C risk category? Is it because her GFR is maintained more than 60 and therefore it is worth putting her on tolvaptan? Is it because she has a history of 2 family members requiring dialysis at a rather young age? Or is it because she has a hypertension at an age less than 35 years of age? So we'll go over one by one. So how about PKD1 truncating mutation?
It's not an indication for the tolvaptan.
It's not an indication for tolvaptan. How about Mayo Class 1C risk category?
Yeah, that's it. Yes, that's what
it is. How about GFR more than 60?
Okay, the answer is A.
The answer is
A.
A?
No.
Oh, the answer is A. Actually, yes, thank you. I didn't pay attention to that. But the A2 is the answer actually, and we'll go one. So, how about GFR more than 60? Is that an indication for tolvaptan? How about people who are advanced for CKD? If you have a patient who comes in polycystic kidney and has a GFR of 22, how about them? Do they benefit from tolvaptan? Or is that somebody who's already CKD4 and should not be considered?
They would benefit, but if GFR is above 60, like we need to train the GFR. If it's going down, they will benefit. But if it is above 60, I don't think. The Mayo Class was the one I remember.
Right, so the GFR is not a determining factor. Actually, after TEMPO, there was another study done, and it showed that even patients with advanced CKD4 do benefit from being on Genarti. So we do not consider GFR as the sole reason for denying treatment. So the answer is actually Mayo Class 1C risk category. So we'll go over what that means. So this patient is high risk for progression based on her Mayo classification. And what is Mayo classification? So what we do is, when we have a patient with polycystic kidney, we do an MRI or a CT scan to reliably measure the kidney size. And the kidney size you're measuring is the height, the width, and the depth. And then we put it into an ellipsoid equation to find the volume of the kidney. So the volume is determined by pi by 6, length times width times depth. Then you combine the 2 kidneys volume to calculate the total kidney volume. And then we height adjust the total kidney volume, which is basically total kidney volume divided by the height in meters. So we came up with a height adjusted total kidney volume. Now, after that, we put the patient's height adjusted total kidney volume into this graph. So Mayo Clinic had this study that they came up with this graph on, and this is the height adjusted total kidney volume, and this is the age of the patient. So we find the age of the patient and we dot where is the height adjusted total kidney volume of this patient. So this patient was 500 something, so that we put her in class 1C. Now, class 1A and class 1B are at relatively low risk for progression of PKD, and we'll go over in the next slide what that means. Class C, D, and E are at high risk. So even visually, you can see for any particular age, class C, D, and E tends to have larger kidneys, right? And in polycystic kidney, what happens is actually, it's not the number of cysts that increase over time, it's the volume of the cysts that start increasing, and that leads to more and more pressure on the interstitium. And eventually, the GFR goes down because of interstitial scarring. And therefore, it has been shown that the height of the kidney at any one point does determine the progression of autosomal dominant polycystic kidney disease. So, in this study, what it was found is that patients in class 1A and 1B, their GFR goes down at the rate of 0.2 and 1.3 milliliters per minute per year, which is not a rapid progression because even age-associated kidney function decline is considered to be about 1 GFR per year. Now, 1C, 1D, and 1E, as we can see, the GFR goes down by 2.6, so almost double compared to 1B, 3.4, and 4.7 milliliters per year. Now, that is a significant decline in the GFR. And that's why C, D, and E are the classes that are considered to be the people who can benefit from tolvaptan. Tolvaptan reduces the GFR rate, so these patients unfortunately still tend to have declining kidney function over time. It's just that the speed with which the GFR is declining can be reduced with tolvaptan. Now, also to be seen that in the same risk categories, the volume of the kidney goes proportionate to the GFR decline. So in class 1A and 1B, the volume of the kidney increases only by maybe 1.5 to 3% a year. But in C, D, and E, about 4.5%, 6%, and more than 6% per year. So the volume does correlate inversely to the decline in the GFR. And that's why what we do is we don't consider the GFR solely, because we take a snapshot, take the kidney size, plot the patient, and see what risk category the patient is. We already talked about that. Now, there's another tool that is often used in Europe as well, actually. It's called ProPKD. Now, ProPKD is another calculator, and that incorporates the gender of the patient, the criteria of hypertension, and if there is any urologic event before 35 years of age, like gross hematuria or an infected cyst. Now, the genotype is also included, which until now, we do not have the possibility of honestly checking genotype on every single patient till Natera become available. But what happens is actually, even though ProPKD is also able to determine the risk of progression, each one of these individual factors, like the gender, the hypertension, the urologic event, individually are not shown to be the predictor of GFR decline. And that's why ProPKD is rather more cumbersome to evaluate. The Mayo classification is much more easier and is much more widely used.
So back you did MRI for this patient, right? But you can do either.
So it is recommended to do an MRI or a CT because it gives us much more proportional. And ultrasound has not been correlated. So what they suggest is actually if for some reason a patient cannot get an MRI or a CT, then an ultrasound volume can be used. But the guidelines is still MRI or CT preferable. Is that what you were asking? All right, any questions on this one?
It's lifelong therapy, right?
Lifelong therapy, yes. Yes. And even if they progress, so I actually have a patient who came to me and she is young, she's about 30, but her GFR is actually 22. Now, sometimes, so one thing I would like to say, these are suggestions that patient with 1C, 1D, and 1E should be on tolvaptan, but it doesn't mean that if you have a patient who is young, but has advanced disease and does not necessarily fall into the class, cannot be a candidate for tolvaptan. You can still order it. It's just that insurance may not necessarily approve it the first time. We might actually do a letter exchange. But I got it approved for. Okay, case 2, the young and unusual patient. So a 35-year-old man presents to the clinic for evaluation of chronic kidney disease. His past medical history is notable only for gout, 35-year-old. He had his first attack of gout at 24 years of age, and since then he has a flare every 2 to 3 years. His family history is significant for several family members with end-stage kidney disease, including his father and his brother at 45 and 41 years of age, respectively. His sister is 35 years old and she has CKD of unknown cause. He does not take any medications besides low-dose ibuprofen when he gets his gout attacks. Physical examination is unremarkable, vital signs unknown. The laboratory data are like this. So creatinine is 1.9, potassium 3.5, his uric acid is elevated at 9.1, C3 is normal, C4 is normal, anti-nuclear antibody is negative. Urine pH is 6, specific gravity is isostate urine 1010, there is no protein, there is no blood in the urine. The urine sediment is bland, without hematuria, leukocytosis, or any cast. The ultrasound of the kidney shows a length of 8.5 and 8.8 centimeters, so rather small kidneys. With mildly increased epigenicity, there is no hydronephrosis. Which one of the following is the most appropriate next step in diagnosis? Genetic testing, kidney biopsy, G6PD because you want to start him on hyperuricemic therapy, serum antiphospholipase A2 receptor antibody, or whole blood lead level. So before we go into the option, any takers as to what do we think this is?
Uric acid.
So what do you think this patient has? 35-year-old patient strong family history of end-stage kidney disease at a young age. He has gout at a young age, frequent flares, small kidneys which are echogenic, with a bland urine.
Yeah. So it's the strongest statement is a family history, the strongest from the clinical scenario. So he had some sort of genetic uric acid probably problem. So we need to test that genetic. But before treatment, the next step is I think the uric acid is not that much high to treat with
9.1.
9.1.
Target is below 6.
Yeah. So
In any gout patient, you target uric acid.
so and phospholipid receptor, these are from blood cells, which no, but I will go for genetic testing.
So what do we have possibilities as to what we think this patient might have?
Yeah, yes.
Some HG.
Was
Was that the HG something or another? It's a three or four letter condition.
Yeah, lot of conditions like that, right? Okay, but I think Ephraim is right on the point. The idea is to go to genetic testing, and the guidelines have been modified that when you have a patient with kidney disease of unclear origin, and we cannot diagnose them based on our common test, you should go for genetic testing. Would you do kidney biopsy on this patient? So kidney biopsy is often done for glomerular causes,
Yes.
right? So this patient does not have any hematuria, does not have any proteinuria, so it's unlikely that there is a glomerular process going on. It is very possible, given the small kidneys and scarring, that there is an interstitial process going on. So it's a tubular interstitial kidney disease. G6PD assay will be done if we are starting this patient on
Medication, yes.
which kind of medication? Which kind of uric acid medication do we check G6PD for?
Respiratory
Respiratory. So this patient actually is not a candidate for respiratory that is used for tumor lysis syndrome.
Yeah.
Usually G6PD is not required to be done before starting patients on allopurinol or pegocistat. Phospholipid A2 receptor antibody is not required here because that PLA2R is done in patients with membranous nephropathy when you're considering primary membranous. How about whole blood lead level?
Lead?
Can it be lead nephropathy?
I think the genetic part makes it unlikely, in the sense that,
Yeah.
yeah,
Family member.
but certainly you can check that out.
So yes,
I mean,
lead
you
nephropathy
say
can be.
usually they will give you anemia, like, right? Like,
Exactly. So this patient does not have
anemia.
anemia.
Like usually they want you to pick that, they would add anemia.
Right. So this
So
patient
that
does not
kind of
have anemia.
raises your suspicion.
And so that's one point for sure. Whole blood lead level is actually not directly related to lead nephropathy. So if you have a patient who's you're considering as lead nephropathy, the whole blood lead level often is not relevant, and what we end up doing is actually end up doing chelation therapy and then checking the lead excretion. If that is increased, that's when lead nephropathy can be diagnosed. So a whole blood lead level is not often diagnosed, even in patients with true lead nephropathy.
Is there any clinical scenario like you're coming across with lead nephropathies?
So I actually have one patient who has anemia and has gums spotting, and I checked the lead level on it. It wants to be negative, but sometimes.
With that patient, are you going to chelate them first?
So I did the whole blood actually because I don't know honestly how to chelate them and then check it. I guess that's something we'll have to find out from our pathologist friends. But that is the recommendation. If you're thinking lead nephropathy, the whole blood lead being negative does not rule out lead nephropathy. You're supposed to do a chelation and then do a whole different lead excretion.
Usually this is like pediatric cases, right?
No, we see lead nephropathy because painters, for example, and people who are working in construction in older buildings, they're actually the risk factor for the exposure.
It used to be more in 1990s, I think.
And then it's described in
Isn't it
pediatrics
like
usually,
now?
like currently in the United
Because
States.
people
But-
don't know, like, you know.
Unleaded gas, right?
But we also have, in Houston, we have a pretty decent immigrant population, so sometimes when people come from other countries and they have chronic kidney disease of unknown origin, we still have to think about their exposures.
I didn't know that you get.
Lesch-Lehmann syndrome, right?
Lesch-Lehmann, yes.
Yeah, Lesch-Lehmann.
Oh, wow, yeah. What does that mean?
No, Dr. Lesch it was our chairman of medicine in the
Oh,
hospital, yeah.
I see.
So he discovered it.
Made sure you all remember.
So this patient with gout, family history of ESCD and chronic kidney disease should have genetic testing as the next step. Genetic etiology is identified in as much as 10 to 40% of the patients with unknown CKD, depending on the cohort issues, of course. Now, whole exome sequencing in adult patients with CKD has a lower diagnostic yield, about 10% to 15%. This is not something that is commercially available to you. The Natera test, the mouth swab that you use, is actually a modification of the exome sequencing. And what they do is a directed exome sequencing. So it's not a whole exome sequencing. They only look for those 372 genes that they test for, but it's actually based on the exome sequencing. So this patient has what we call ADT-KD, autosomal dominant tubular interstitial kidney disease. Previously used to be called medullary cystic kidney disease. Why the name change? Because these patients are not required to have cysts for the diagnosis of medullary cystic kidney disease. In fact, a lot of these patients, 30% almost, don't have any cysts, even though they have an defect. ADT-KD can happen because of mutations in 5 different genes. One of them you commonly know, the uromodulin, the UMOD. The other I could not even pronounce, so we will not go into it. But uromodulin is the most common defect in patients with ADT-KD, medullary cystic kidney disease. And this is common. I actually have a patient with medullary cystic kidney. Why it is also important to know to do genetic testing in these patients is sometimes the treatment can be different. So for example, out of all these 5 genes, only UMOD is the one where the treatment of hyperuricemia still affects their GFR decline. So the patients with ADT-KD should be treated with hyperuricemic therapy, contrary to what we know in chronic kidney disease and high uric acid, that allopurinol is not shown to affect GFR decline. Patients with uromodulin should be treated with allopurinol. Among patients with CKD undergoing genetic testing, what are the common genetic tests that come out to be positive? PKD1, PKD2, call A4, A3, and 4A5, which is what? Yeah, collagen 4, alpha 3, and alpha 5, which is what kidney condition, Alport syndrome. So Alport syndrome is commonly found, and the fourth one that is commonly found is uromodulin gene defect. So PKD1 and 2 are the commonest in genetic testing that we find in patients with unexplained disease. Collagen 4, alpha 3, alpha 5, and then uromodulin.
I have a patient, the HNF1B, that's what I was thinking.
I have a patient too. Those patients actually come up with polycystic kidney disease as well. And tolvaptan is not indicated for that because those patients tend to progress slowly. So yes, very good. GCSPD testing is required for initiation of rasbutase, not for allopurinol, and we already talked about the letter. Okay, moving on. Case 3, the case of the yellow bead. 17-year-old man presents to the clinic for evaluation of nephrolithiasis. 2 weeks ago, he presented to the emergency department with right-sided flanking. A CT scan of the abdomen and pelvis demonstrated a 4 mm stone in the right distal ureter with mild hydronephrosis. Incidentally, he also had a 1.2 cm Staghorn calculus in the left kidney. He was treated with tamsulosin and discharged for a trial of passage. He reports that he passed a stone 3 days ago, which he is bringing with him to the clinic today. The kidney stone measures 3.5 mm in length and is yellow in appearance. He currently denies any fevers, chills, dysuria. He does not have any visible hematuria, no abdominal pain, no bowel blank. He reports the family history of kidney stones in his paternal grandfather. This is the bead that he brings with him.
Cystinuria, yeah. It looked like con.
This is, these are his studies. Potassium is 4.8, so normal. Bicarbonate is normal. BUN is 18. Creatinine is 1.1. Albumin is normal. Calcium is normal. AST, ALT, alphos are all normal, and the urine is normal. The urinalysis demonstrates a pH of 6. Specific gravity 1010. There is 2 plus blood and negative protein. There are no decastrates. There is no nitrate. In addition to sending the stone for analysis, which one of the following would best establish a diagnosis? And we'll go over each one of them. Ash leaf spots and facial angiofibromas on skin examination. Which condition brings those?
The ash leaf spots are for patient with tuberous.
Tuberous sclerosis. So does it sound like tuberous sclerosis?
No.
Okay. Crystalline deposits in the cornea on eye examination. Okay, this one is tricky, we'll go over that. Anhydrosis and periumbilical angiokeratomas on the skin examination. That's what it is. Fabry's disease. Fabry's disease. hexagonal crystals on urine microscopy. What are hexagonal crystals on urine microscopy?
It's cysteine, right?
Cysteine, right? So this is cystinuria. And yeah, cysteine stones are pretty typical in their appearance. They look yellow and brown. So the presence of pathognomic hexagonal crystals on urine microscopy is confirmation for cystinuria. The development of bilateral stones and a staghorn calculus in the second decade of life. So these patients usually present not at young age, but actually in their 20s, usually with nephrolithiasis, and a positive family history should prompt an evaluation for cystinuria. So what is cystinuria? It is an autosomal recessive disorder, and it is caused by the mutation of a dibasic amino acid transporter in the proximal tubule. So we have a bunch of transporters in the proximal tubule, and it is job of this transporter to transport 4 amino acids. And I remember this by COAL, C-O-A-L, C for cysteine, O for ornithine, A for arginine, and L for lysine. So this transporter, the job of it is to absorb all of these amino acids from the urine. In these patients, there is a defect in this transporter. It is not able to do its job very nicely. Now, as it happens, ornithine, lysine, and arginine are very water soluble at normal urine pH, so we don't get crystals of them. But cysteine is not soluble at physiologically urine pH, so we actually get a crystal, and over a period of time leads to, of course, nephrolithiasis. How do we diagnose cystinuria? Measurement of 24-hour urine cysteine excretion is used to diagnose cystinuria, and it is actually something you have to order separate from your stone risk analysis. So we have a panel at Quest called stone risk analysis, and cysteine is actually not a part of it. You have to order 24-hour urine cysteine as a separate test. So if you missed it, you'll miss the diagnosis. Those are the urinary hexagonal crystals, classic for cystinuria. Now, Ashleigh spots and angiofibromas, characteristics of tuberous sclerosis complex. Now, tuberous sclerosis complex usually presents with kidney angiomyolipoma, so they can show as tumors, and angiomyolipomas can bleed, but usually tuberous sclerosis does not lead to nephrolithiasis. Now, I intentionally put this here. The cystine crystal deposits in the cornea and conjunctiva is actually cystinosis. Now, cystinosis and cystinuria are entirely different diseases. Cystinuria, like we saw, is a transporter defect in the proximal tubule. Cystinosis is actually an autosomal recessive lysosomal storage disease in which there is a defect in a gene called CTNS or cystinosin. The job of cystinosin is to transport amino acids from the lysosomes to outside of the lysosome. So when this transporter is not working, the cysteine tends to accumulate in the lysosomes, and over a period of time, it can reach deposition in kidney and other tissues. This is classically seen in cornea. So this is something that can be actually seen in children as young as 1 to 5 years of age when they have cystinosis. This is what the eye looks like. There are like powder kind deposits in the cornea, and it is very classic on slit lamp examination. It actually looks like a star sky pattern in the cornea. Classic for cystinosis. Now, cystinosis and cystinuria usually don't coexist because they're different diseases. It's rare that you get cystinosis and cystinuria in the same patient. We already talked about these. Now, angiokeratomas. Angiokeratomas, especially around the periumbilical region, are something that we see in Fabry's disease. Fabry disease is yet another genetic condition in which there is deposit of triacylceramides in the lysosomes. This is a kidney biopsy. The kidney biopsy actually shows these things, and these are called lamellar patterns. So a kidney biopsy classically showing lamellar patterns is actually diagnostic of Fabry's disease. Okay.
I've had a couple of those patients.
Fabry's? Are they getting infusions?
Yeah, Fabry's.
Those people do very well once they start infusion. All right, we move on. Next case, the stem cell. 75-year-old man with a long-standing history of type 2 diabetes and mantle cell lymphoma is evaluated for new-onset proteinuria. Diabetes has been well controlled. There is no retinopathy reported on his recent eye examination. His lymphoma was diagnosed 3 years ago. He undergot stem cell transplant of the autologous type, and he was conditioned with cyclophosphamide, fludarabine, and total body irradiation. The autologous transplant was unsuccessful, so they actually had to go for an allogeneic stem cell transplant. Now, after the allogeneic stem cell transplant, he actually got graft versus host disease after 7 months, but initially he was given prophylaxis with tacrolimus, sirolimus, and methotrexate. 8 months he got stem cell, after stem cell transplant, he got skin GVHD, and that was treated with prednisone, and the prophylaxis was stopped at 7 months. So 7 months prophylaxis stopped, 8 months he get skin GVHD. He's now 13 months still exposed to the allogeneic SCD. He feels well, but notes that he has now edema in the lower extremity and is foamy-urine. He is not taking any NSAIDs, he is not taking any over-the-counter medications. Blood pressure is elevated, 165/96, already 76. There's periorbital edema and lower extremities with this edema in the thighs. This is the report. WBC is elevated 43,000, hemoglobin 14.2, platelets are normal, creatinine is 1.1, which is baseline, glucose 243 elevated. Lactate dehydrogenase is 240, just a bit elevated. Haptoglobin is low, haptoglobin is normal at 53. Albumin is low at 2.1, and there is BK virus plasma titers at 2,000 copies per milliliter. So WBC is elevated, everything else is normal. Slight elevation of the LDH, BK virus 2,000 in the plasma. Doing analysis, the specific gravity 1027, 4 plus protein, 7 RBCs, 2 WBCs. 24-hour protein, 11 gram. Which one of the most following is the most likely cause of proteinuria in this patient? Thrombotic microangiopathy, BK virus nephropathy, membranous nephropathy, diabetic nephropathy.
Do we have a lipid profile? We don't have, right?
We don't have it.
Okay.
What are you trying to think with this?
No, just because this hypoalbuminemic is proteinuria of like class 4, maybe corresponds to the potassium for our protein of like more than 3.5. I'm just classifying nephrotic range, like case of glomerular disease. So
nephrotic range proteinuria he clearly is because he has 11 grams. You're trying to classify whether he's nephrotic syndrome.
yes,
or
yes,
nephrotic range.
yes.
We don't know that yet.
Yeah, so most likely, so that is not. I don't think that is history. How long? Like,
He has a history of diabetic nephropathy. It is well controlled, no histopathology.
Yeah, exactly. No retinopathy. So it's unlikely diabetes. You already know the answer. So my patient is like it's nephrotic syndrome range, like primary glomerulopathies, membranous, and FSHs, and of course like minimal shape, younger or even older, plus the FSHs, membranous.
So the patient has history of lymphoma.
Yeah, lymphoma, yeah. So lymphoma like are hematologic malignancy, right? Solid malignancy versus hematologic malignancy from the two secondary causes of I think it's for membranous, okay, FSHs.
Now, lymphomas can actually cause minimal change as well if it is uncontrolled, but looks like this lymphoma is controlled. So how about thrombotic microangiopathy?
Those are, I'm thinking like more of coagulopathies issues, like of course any nephrotic patients are prone for that, but it should be, is non-renal failure, okay? In thrombotic microangiopathy, usually you would see nephritic means, right?
So you present as nephritic syndrome. Now, thrombotic microangiopathy can actually often happen because of antigen-antibody reaction, like antibody-mediated cell rejection. That's why it is in the options. But this patient's actually, platelets are normal, right? Hemoglobin is normal. Platelets are normal and hemoglobin is normal. So it's unlikely that he has thrombotic microangiopathy along with the normal.
You're right.
So there's not a big thrombotic microangiopathy. How about BK virus nephropathy? What is that?
Usually it's after transplant, kidney transplant we see, but for hematologic, I'm not
So
sure.
it actually happens after any transplant, whenever there is immunosuppression. So BK virus is an opportunistic infection.
Also, if there should be renal declining renal function, is there with no, I don't think this level of kidney function. BK.
Correct. Slowly declining kidney function.
Yes.
Small amount of proteinuria with some microangiopathy is the BK virus nephropathy. And BK virus nephropathy often is diagnosed with plasma BK virus level, but usually you look for copies more than 10,000 per ml. So 2,000 per ml is low virus BK viremia, low level BK viremia. So membranous nephropathy is something we see with chronic inflammatory condition and yes, with lymphomas over time. So BK virus nephropathy, as we said, the plasma level more than 10,000 per ml is what we see. presents at the AKI, varying degrees of dysuria and uraturia, and often with actually urologic manifestations like inflammatory cystitis. BK viremia itself does not cause nephrotic syndrome. It has to be BK virus that properly because proteinuria kidney disease, even then it is usually not nephrotic syndrome. Diabetes is unlikely because it does not generate retinopathy, and the edema is rather new onset. That's not how diabetes presents.
You always learned in fellowship that BK is very rare in non-kidney cancer. That like a heart, liver, whenever we saw this, it's very rare for it to be.
Right.
And I don't think anyone ever knew the answer, so
So BK viremia happens a lot more. BK nephropathy is less common.
oh.
All right, next case. You have some time. I take too many medications, that's what it is. 60-year-old man with CKD 3A, A1, so low level albuminuria, hypertension, and rheumatoid arthritis, presents to nephrology clinic for follow-up. He has a history of rheumatoid arthritis that has progressed despite treatment with methotrexate, so infliximab was added to his regimen 6 months ago. Over the last 3 weeks, he has noted increasing hair loss, photosensitivity, and joint pain. He started taking some ibuprofen for it. His other medications are lodipine, lisinopril, clopidogrel, and methotrexate. Examination-wise, blood pressure 160/80, heart rate is 80. He is not in any acute distress, and no evidence of cardiac murmur or rub. He has trace peripheral edema. On examination, his blood pressure is 160/80, heart rate is 80. The patient says, I just take too many medications, that's what it is. The serum creatinine is 3, reference range is 0.7 to 1.3, baseline was 1.7, so his creatinine is worsening. Urinalysis shows microscopic hematuria, protein to creatinine ratio is 3.5 gram per gram, so nephrotic range. Urine microscopy shows this. What is this?
This, for me, like WTC casters look like, or groundnut casters, maybe I'm not sure. Like,
So
for me,
there's something going on here. This is a cast, right?
yes,
We see something in the cast, but something of the similar type here. That's not
that is
RBC.
RBC.
Right.
That's RBC.
So what
This is so, okay, since it's RBC casters.
right, but with white cells, actually, you should see some nucleus, right?
Yes.
None of them actually have a nucleus. This is not a WBC.
Okay, for me, the comparisons that you show us at RBC, I see them more. Otherwise, the color is, like when you see in the microscope, this is it's a little bit confusing for me, WBC casters versus RBC casters. Sometimes even groundnut casters, okay, like when you see them like it. But in the microscope, I really differentiate between the RBC.
So the way to look here is actually there is no nucleus in here, right?
Okay,
So this is
okay.
likely to be WBC.
So it's RBC?
Hmm?
Okay. I wish you could have also.
Like at least for the board questions, like if you have a good circle and there's nothing you see inside, even if you see 2 or 3 of them in the cast, like very clearly, and I would not call it a WBC, I would call it a RBC cast, I think if you're thinking of that. Because with the WBC cast, they'll clearly show you something inside, like, in majority of the.
Okay, so to revise, we got a 60-year-old man who's now on infliximab 6 months ago. He has proteinuria 3.5 gram, right? So the product is proteinuria, and he has obviously cast. Kidney biopsy reveals diffuse proliferative glomerulonephritis. Immunofluorescence shows a full house staining pattern for complex C3, C4, C1q, and all the 3 immunoglobulins, G, A, M. That's what the kidney biopsy looks like. So, what do you see? None of the capillary loops are open, right? Everything, too many cells. This is too busy. Too many cells, there's actually a little bit of, lobulation, and he has no open capillary loops. So this is diffuse proliferative glomerulonephritis. Which one of the following is the most likely cause of this patient's clinical presentation and biopsy findings? Infliximab, hypertension, ibuprofen, rheumatoid arthritis itself, or the methotrexate?
So even if you don't know anything about nephrology, like, just the case presentation, like one of them is too much, right? One of the medications, the hair loss and everything.
I don't think so.
No, but hair loss is like you get with all the factors.
I know.
And even methotrexate. Hair loss is very common. So any takers, how about infliximab? So let's go this. How do we approach this? We got a patient with diffuse proliferative glomerulonephritis and a full house pattern. What does a full house pattern mean?
Full house pattern is usually in lupus nephritis. That's the full house. That
Correct.
means you see all the immunoglobulins,
Correct.
A, G, M, everything, and then complement also.
Correct. So we got a patient who has actually rheumatoid arthritis.
Yeah.
We treat him somehow, and now he has lupus-like picture.
Yes.
Does that mean he generated lupus now? Or is this pseudo-lupus? Or drug-induced lupus?
Drug-induced lupus would be the probably.
How likely it is that somebody with rheumatoid arthritis, while we are treating in 6 months, suddenly develops another autoimmune phenomenon, right?
Yeah.
So it seems like drug-induced lupus. So now the question is, which one of these medications can cause drug-induced lupus? So hypertension is out. Hypertension is caused chronic kidney disease.
No, hypertension is out, ibuprofen is out. I don't
Well, why is ibuprofen out? What is ibuprofen?
see. It doesn't cause lupus nephritis. In
Correct.
lupus, the drugs are specific,
Like for procainamide, hydralazine,
yes.
and then
I can reduce the ionization.
Right, HIV.
Yeah.
Hydrolysine,
Yes.
acetylcysteine,
Yeah.
are the common ones.
So,
So ibuprofen can cause what kind of kidney disease? It can cause minimal change disease like a platter and can even cause membranous actually in some types of cysts. Rheumatoid arthritis itself can cause vasculitis picture, but doesn't usually present like lupus, mitoplatin. Methotrexate can cause crystalline nephropathy, but usually not lupus kind of picture. So yeah, that takes time. So TNF alpha, as it happens, all the three common TNF alpha, infliximab, etanercept, and adalimumab, have been shown to result in drug-induced lupus. It is not common, but it does happen. Now, we use TNF alpha actually only in certain conditions. The GI doctors use it a lot. So if you have a patient who has Crohn's disease or ulcerative colitis and is getting these medications and presents to you with a lupus-like picture, don't think they have a second autoimmune condition. They actually have to evaluate for drug-induced lupus. So infliximab out of these three is actually even more likely to cause drug-induced lupus. Skin involvement is often the first and more common ones, but lupus nephritis has been reported in these medications. Presents as diffuse proliferative lupus, just like a classic lupus case. Why that happens is because TNF alpha is the cytokine imbalance along with the induction of apoptosis in inflammatory cells. That basically leads to driving of antigen antibody formation, and that's what leads to drug-induced lupus picture. Malignant hypertension, as we know, can cause AKI, but equally leads to endotheliopathy. This is microencephalic hemolytic anemia, not as an antigen antibody complex picture. Ibuprofen and NSAIDs, as I said, can cause interstitial nephritis, membranous nephropathy. And methotrexate can cause crystal deposits in the urine, even interstitial nephritis, but not lupus kind of picture. Okay, I think we have time for one more. Okay, the hamburger. 32-year-old man presents to the emergency department with dyspnea, nausea, vomiting, malaise, and headache. 1 week ago, he developed watery diarrhea. The diarrhea persisted for several days after eating a hamburger at a local restaurant. He has a history of stage 1 hypertension for 3 years, but does not take any medications. There is no history of any drug use, travel, no history of any exposure to any animals. Examination, blood pressure is too high, 230 over 124, his pulse is 80. Endoscopy reveals no evidence of hypertensive retinopathy. And as for Gallup, bidigital Cracov's 1 plus max pressure. Neurological examination, including medication, is normal. Chest X-ray reveals patchy opacity is consistent with pulmonary edema. Peripheral blood smear shows cystocytes. Ultrasound shows hyperechoic kidneys, 10 centimeters in length. There is no evidence of hypernephrosis. He receives Lasix and Levitidon, and that improves his headache and hypertension within 2 days. We do a lab data at day 5 of his hospitalization, and this is what it looks like. So this is the first column is admission, the second is day 5. Hemoglobin 10.2 upon admission, now 9.4. It was 60,000 on admission, now 49,000. P1 64, now 72. Creatinine is worsening, 4.8, now 67, 6.7. Lactate dehydrogenase was elevated on admission, 850, still elevated, 820. Haptoglobin is low, 33. C3, normal. Sorry, C3 slightly low, okay, 95, 86. C4 is normal. Plasma and INR and PGT are all normal. There is PCR done for E. coli 157 and 7 and that is negative. Sugar toxin assay is done and that is negative. So what do you think so far?
So it is kind of microangiopathy process, like hemolysis is going on, absorbed low, and then platelet is like high, or hemolysis is there, and then it's fast AKI, like or whatever he's developing.
So microangiopathic
AKI
hemolytic anemia,
and the thrombocytopenic anemia, all these are in favor of microangiopathy.
T3 is kinda a little bit low.
Yeah, yes.
Okay.
So C3 is very specifically to differentiate between nephritic case of, both are usually in lupus, both C3 and C4.
Both are
Both
reduced
will be low.
Low, yeah.
Remember lupus everything.
Yeah. And then one is specifically C3 low in there.
So C3 is low, C4 is normal, and infection associated with murder nephritis. C4 is low, C3 is okay in coagulopathy. Both are low in lupus.
Yeah.
So which of the following is most likely diagnosis? Complement mediated HUS, malignant hypertension, because it is microangiopathic hemolytic anemia, infection associated thrombotic microangiopathy, DIC or PTP.
For me, like the last one, E is a choice. But complement-mediated hemolytic uremic syndrome, also like acquired one, also the same thing. So
You have to look at go back to Adam.
yeah, it is high. Adam's case is high. It is high. So it is the thrombotic thrombotic.
So look at LFT study, 25% and 33%. It says normal is more than 60. Is that low?
Yeah, Adam's activity 13 is like 25 when it comes like, A5 is a little bit okay. But the normal is you have the reference rate, right? It is
Right.
greater than 60%, so it is low.
So
It's not so low, you're saying 10%.
right. So the TDP diagnostic criteria for LFT study is less than 10%.
Yeah.
Right. So 25% is actually sufficient LFT study available right now.
Okay.
Less than 10% is the diagnostic criteria. So TDP, LFT study, even though relatively low compared to the population cohort, this is still sufficient. So not TDP.
Okay, so
How about DIC?
DIC, no, I don't.
One.
The DIC is that's very.
Shelly didn't come, so you're the only one getting feedback. So look, this INR is normal. Disseminated intravascular coagulation, which is a consumption coagulopathy,
Yeah.
INR goes up.
Yeah.
His INR is normal,
Yeah. So,
points against DIC. But DIC is also converting microangiopathy. You see the same kind of picture.
yeah.
Malignant hypertension? Yes, possible, it can do that, but then the C3 being low kind of indicates that there is something else going on as well, right? So this is complement-mediated HUS. Now remember the history of diarrhea, what is that got to do?
It is it's like, of course, they developed hemolytic uremic syndrome after GI. So it's mediated by the Escherichia coli.
Correct, so there is D plus HUS, right? Diarrhea-associated hemolytic uremic syndrome, but that happens because of E. coli O157 and 7. Sugar toxin is usually positive because that's usually the inciting factor. Sugar toxin hurts the endothelium, that starts the cascade where you get endotheliopathy and everything starts getting attracted, you get microangiopathy. But here, 157 and 7 is negative, sugar toxin is negative. So even though he had diarrhea, this does not appear to be diarrhea-associated HUS. So this is complement-mediated HUS, and we'll see why. So hemolytic uremic syndrome are TMAs, as we already know, and they are of two types, D plus and D minus. D minus is not called complement-mediated HUS or atypical HUS to be more precise. Depending on the nature of the defect in the alternating pathways, C3 may be low or normal, and we'll see the next slide after this. Infection, including gastroenteritis, is often a common triggering pattern given for atypical HUS. So a lot of the time, these patients have low-level complement activity going on, but the body is able to make enough complement and inhibitors to not go into a full AHUS. But when there is an infection, that can lead to more inflammation, and that often precipitates atypical HUS as well in patients who are at risk. So in this case, as we said, the hemorrhagic enteritis is there, but negative PCR toxin is a 0.8 type, not the positive type. This is the complement cascade in a very simplified way. So we have the classic pathway, which leads to C1, Q, C1, 2, and 3, leading to C1, C2, C3 convertase, which is C4B2A. This is the alternating pathway, where the C3 is directly activated and binds the protein, leading to the, and the C3 convertase is C3BBB, which changes C3 into further C3B, and it starts a cycle, which means once the C3 convertase comes into existence, unless it is stopped, it will keep leaving more C3 and keep making more C3 convertase. So something needs to stop it, right? In our body, we have factor H and factor I, which are the major inhibitors of C3 convertase. So in a normal scenario, when the C3b is activated, the factor H and factor I basically go and put a plug onto this cycle. Patients who have deficiency of factor H and factor I, which is often autoimmune, so think about lupus or think about autoimmune conditions that generated an antibody to factor H or factor I. You get a low level of factor H and factor I, right? In which scenario, if the C3 convertase comes into existence, it is going to be difficult to stop this cascade. That's what is atypical HUS. So basically, factor H and factor I deficiency. Now you can imagine if somebody has C3 atypical HUS like this patient, if you can somehow give them factor H and factor I, that should put a plug to the cascade. And that's why a lot of the time, plasma exchange in these patients is the first line of defense. If plasma exchange, you're able to get the complement stagnant time and you're able to stop the cascade. In the long term, because plasma exchange is not something you can keep doing for life, we can actually give them eculizumab because at the end of the day, why do we even worry about it? Because C3b, a lot of this cascade leads to generation of membrane-related complex and leads to cell destruction, right? So if we can plug in at C5 level with eculizumab, we will still be able to prevent damage. And that's why eculizumab can be a long-term treatment for these patients. So initial treatment, give them plasma exchange, get that complement back in line. Long-term therapy, eculizumab. I think we are done. Should we call it? Sure. Okay,
Yeah.
Thank you so much.
Yeah, very interesting. Thank you.
Thank you.
Yeah.
Effort. Will you help me get ready?
We will meet tomorrow. In the afternoon.
Yeah.
1 o'clock tomorrow. We'll meet 1 o'clock.
We're live now.
So how does this go?
But we're not on call today, right? It's gone. We're not on call. No.
The only thing is, I don't know what the process of bringing this in works.
We wasn't having.
I don't know.
And those are good cases.
Yeah.
Just to say, like, let's say somebody in their house side has a case that hasn't been changed. What are you going to do? Who's going to be in charge?
I know Dr. Harvard, I'm a live person, so.
Okay.
And then I'll announce it to our SCU team.